Thanks for that introduction, Jeff. So as is mentioned, I work for the HIV Legal Network. It's an organization based in Toronto that has an extensive history of working on drug policy and harm reduction issues. And I'm presenting today on the results of some research that some colleagues of mine and I have done in recent years that has informed a number of recommendations about how we might improve the legal framework to achieve, as the title of the presentation suggests, the normalization and greater security for the operation of supervised consumption services in Canada. So I want to start by running fairly quickly through what has been an evolving legal and political landscape against which the implementation of supervised consumption services has taken place. And it is, of course, as many on the panel and attending this conference will know, and as Jeff has pointed out, is something that's been quite controversial over the years. But in order to understand what needs to change, we need to understand what has come before and where things stand now in the law and the politics of supervised consumption services. I think everybody will know, of course, that the Controlled Drugs and Substances Act creates basically the legal backdrop or framework against which this has played out. And in particular, the things that are relevant to the effective operation of supervised consumption services and access to them are the prohibitions, the criminal prohibitions on possession of controlled substances and, to a degree, trafficking of controlled substances. It's also important to know that there are provisions that are part of the overall legal framework that allow for some relief against those default general criminal provisions. And in particular, the one that is most directly relevant is the question of the Federal Minister of Health issuing exemptions under Section 56 of the Controlled Drugs and Substances Act from certain provisions of the CDA for certain people in certain places under certain circumstances. To understand where we are now in that changing legal and political landscape, it's also important to remember that for an extended period of time, we had a federal government that was actively blocking and taking measures, including legal measures, to undermine the operation of supervised consumption services. And for the longest time, until just a few years ago, there was only one supervised consumption service operating in Canada with the legal protection of an exemption from the Federal Minister of Health. And that, of course, was Insight in Vancouver, which, as people will know, was at the center of litigation that went on for several years and ultimately made its way up to the Supreme Court of Canada in 2011. And at each of the three stages of that litigation, the government's position aimed at denying a continued exemption from the CDSA to permit the operation of Insight without the risk of criminal prosecution was rejected by each level of court, including ultimately the Supreme Court of Canada, who ordered the Minister of Health of the day to issue a renewed exemption to Insight in Vancouver. However, that wasn't the end of the matter, and the government of the day responded to that court decision in extraordinarily bad faith by implementing, introducing, and passing the Respect for Communities Act, which I've put in quotation marks here because I think the title is misleading. And the gist of that act was to create a new standalone specific regime for applying for and receiving exemptions from the Federal Minister of Health for specifically a supervised consumption service. So it took what had been a fairly open-ended exemption power under Section 56 that had been used previously to issue the one exemption that had been issued to Insight, and displaced it and said, we're going to have a new regime under a new Section 56.1, and this is the only legal pathway for you to get an exemption from the Federal Minister of Health for the purposes of operating supervised consumption service with exemption from certain parts of the CDSA that would otherwise expose the users of the site and the staff of the site to the potential for criminal prosecution for certain drug offenses. In 2015, there was a new federal government elected, and there was a very significant shift within reasonably short order, although not as short as many of us would have liked. Under the existing restrictive regime that the new government inherited from the previous government, there was one additional exemption issued. This was to the Dr. Peter Center, again in Vancouver, but we still only had a total of 2 sites operating with an exemption, I should add. There were other instances of sites operating without an exemption. And finally, in 2017, the new federal government repealed the restrictive regime, streamlined it substantially, but kept an SCS-specific exemption regime in the Controlled Drugs and Substances Act. There were also some important changes to the accompanying Health Canada policies for how they would review and process these exemption applications that improved the regime somewhat. But it was a significant step forward from the perspective of advocates who wanted to see a simpler, more straightforward process for getting these exemptions, but it was and is by no means ultimately satisfactory to this day. It is important to note that the broader ministerial exemption power in Section 56 of the CDSA that predated this SCS-specific regime and is still there is something that is important to this discussion, and I'll come back to that in a moment. So there are currently 3 pathways in theory, on paper, that could be used in order to carve out the exempt from criminal prosecution space for supervised consumption services. So there's the existing, continuing but improved exemption power under Section 56.1 that is specific to supervised consumption services. And the policy that accompanies this provision that Health Canada has put in place have also continued to evolve. Some hurdles have been removed in recent years. And that remains the provision under which all of the exemptions to date have been issued, with the exception, of course, of the original inside exemption that predated this new specific provision. There is, as I said, this general, more broadly worded power on the part of the Federal Minister of Health under Section 56 to issue an exemption to a person or class of persons in relation to a substance or any substance or class of substances in relation to any provision of the CDSA if the minister is of the view that to do so is in not only the medical or is not only for a medical or scientific purpose, but is otherwise in the public interest. So there is a broader basis on which to exercise this broader ministerial exemption power. And this is quite specific to the recommendation, or quite relevant to the recommendations that we have been pursuing with the federal government. And finally, just to note that on paper, the federal cabinet, of course, has a power to adopt regulations under the CDSA, and the penultimate provision of the section, which is 55 in the CDSA, that sets out the regulation-making power of cabinet, is very open-ended and affords a great deal of latitude if there's the political will on the part of the federal cabinet to adopt regulations on a particular matter, including to facilitate the expansion of supervised consumption services. So this changed political environment and this changed legislative landscape has been hugely significant, and we see it in, of course, the numbers of supervised consumption services now operating. Under the old regime, we succeeded in ultimately having 2 exemptions issued. As of today, there are 38 supervised consumption services operating with ministerial exemptions under the CDSA. Of course, in those recent years, we've also seen a staggering number of overdose deaths, none of which have happened in supervised consumption services, further underscoring one of the many, many reasons to actually facilitate the expansion and implementation of these services on a broader scale than they currently exist. So our research project that is the basis of the recommendations that I'm presenting today was one that we undertook in 2018 with the goal of identifying the facilitators in the environment for scaling up supervised consumption services, but also what are the continued barriers and therefore things that may need to change. And we undertook that literature review, a number of key informant interviews, and had the benefit of an advisory committee reviewing the research questions and analysis. So key findings on the positive side, there have been a number of improvements in recent years, including the degree of communication and the transparency of Health Canada in its interactions with those who are applying for exemptions. There has also been a greater openness to considering new models, new features of supervised consumption services, including expanding to authorize various modes of use, so not just injection of substances, new locations, including in a hospital, for example, in Alberta. More recently, some experimenting with allowing the assistance with injection, although at the moment it is only permitted under the terms of the exemptions for someone using the service to assist someone else using the service. Staff, including nurses, for example, who work in those services, have not yet been permitted to assist with injection. And again, in more recent years, a number of services have actually added, a number of SCSs have added drug checking services to the array of things that are accessible to people when they visit a service. As I noted, the process for applying for an exemption and the requirements that are in place have been significantly streamlined from what had been legislated in place under the previous government, with a very clear attempt to make it almost impossible to get through the application process and to get a positive decision from the minister. And it's been really important that SCS providers have been sharing information about how to put together applications, what are good practices in delivering SCS, and underscoring all of this, of course, as I think everybody recognizes, is the community activism that has driven some of these legislative changes, some of these policy changes, and have been successful in part because they've been directed to a government that has been more receptive to harm reduction as a principle and a practice, including supervised consumption services, unlike the previous government. However, there are a number of barriers that remain. The process is still overly burdensome for frontline service providers. There are still a number of criteria in the requirements that Health Canada is imposing, including the requirement that there be a report of a mandatory community consultation by a would-be provider. This is not something that is actually statutorily required, but Health Canada has made a policy choice to mandate that as part of the application process, and that remains a problem that was identified over and over. There had been one-year terms of exemptions. There has been more flexibility on that recently since we put out the report, so that is good. And there have been concerns about some of the reporting obligations that have been imposed on recipients of exemptions that are problematic. So what needs to happen now? It was identified that there needs to be a broader range of SCS services offering different kinds of services at a given site. And there has been movement on some of these things since the report that we put out. There remains a significant disparity in approach between provinces and municipalities. There are only 4 provinces at this point that actually have SCS operating with, 5 provinces that have an SCS operating with an exemption. Clearly, there is a need for such services elsewhere, but there remains a challenge there. There's been a growing discussion about using SCS as one means of ensuring access to a safer supply of substances, which is gaining some traction, and that I think is important. And there always needs to be support for the involvement of people who use drugs in the design and delivery of those things. So given the facilitators, the barriers, and the needs that have been identified, what can we conclude from this? A couple of overarching observations. The first is that we continue to treat a health service, such as supervised consumption service, in a fairly exceptional way in our law and our policy. And this is reflected in part by the case-by-case approach that is currently mandated by the government and law for getting exemptions so that these services can operate without risk of prosecution. And that is rooted in stigma. It's unnecessarily restrictive. It impedes the rapid implementation of these services, although that has improved of late. There is still room for improvement. And it renders them vulnerable to political change, because we saw that if there is a willingness on the part of the Federal Minister of Health, i.e. the federal government of the day, to make the system work, then much more is possible than if there is a desire to actually be obstructionist and prevent such services from operating. Obviously, one cannot, with legislative or policy changes, completely immunize these services from political change, because things can change when a government does. But the current approach that we've seen so far seems particularly vulnerable to that problem rather than a decision on the merits of these services. So we need a shift from this case-by-case approach to one that is much more automatic or quasi-automatic for getting these exemptions from the potential of criminal prosecution, so that we can basically get the legislative and regulatory framework out of the way of service providers who are trying to actually deal with services and provide services on the front line. And of course, there needs to be funding to support those services, which remains an ongoing challenge. But let me just focus to conclude on some very specific recommendations. I think we need to always say, first and foremost, that if we were to decriminalize activities related to personal drug use, for which there is broad and growing support, albeit not yet enough on the part of the current federal government, then much of this discussion would become irrelevant. We're only going through all of these contortions for years now because there is the underlying criminalization of activities related to personal drug use. And by that, I mean not only possession for personal use, but also the trafficking of small quantities. So sharing between people, for example, is technically trafficking under the law. If we could get rid of this criminal backdrop, this shadow of criminalization, then much of what I'm about to present as alternatives would actually become unnecessary. Assuming that that is not going to happen in the short term, maybe not even in the medium term, although one might hope that it will, then we could at least, as long as the criminalization backdrop remains, we could at least move away from this still unnecessarily cumbersome case-by-case approach to a more class-based approach so that we could get a broad class exemption for the clients and providers of supervised consumption services, as long as they meet certain basic criteria that could be set out in legislation or in exemption conditions or in regulations. And you see some examples here of what people in the research project felt would be reasonable minimum conditions. And basically, we need a legal framework that says any service provider who meets these criteria is automatically exempted from the application of the provisions of the CDSA that would otherwise pose a risk of criminal prosecution. There are three ways that this could be done. So going back to what I spoke of before. So we could use the open-ended ministerial exemption power under Section 56 of the CDSA to exempt all SCS providers and clients who are engaged in a service that meets certain minimum criteria, like the ones I've noted here. Alternatively, Cabinet could say the same thing substantively, but in the form of a regulation that it adopts. Or in theory, Parliament could change the CDSA to replace the current legislative framework with a simpler one like what I've described. Obviously, the quickest and most direct and easiest way to do that is through the use of the existing ministerial exemption power, which is why I've highlighted it here. And that is something that could be done tomorrow if there were the political will to do so. As a further alternative, if that is not the approach taken, although frankly it needs to be, and we maintain this case-by-case approach for each individual service applying each time for an exemption and jumping through the hoops that remain, we should reduce further the hoops and get rid of things like the mandatory community consultation, et cetera. And it's important to note that while all of those things are within the purview of the federal government, of course, provinces and territories and municipalities do have some potential to throw further wrenches into the works here and get up to some monkey business with what they might do via provincial requirements or municipal bylaws or conditions of funding that they may provide for such services if they're willing to provide such funding at all. And that is something that we also need to address if and when it arises, which it has in a number of cases already, including in Ontario, for example. So there's work to be done at both levels, but the first thing to do is to get the federal exemption regime working more simply and straightforwardly in the way that we think it can. And I just want to acknowledge the people who also contributed to this work and the funder, the Public Health Agency of Canada. And you can find the full report on our website at the URL that I've indicated. Thank you very much.
Thank you very much, Richard. That was excellent. And I'd just like to remind the participants that we're going to move through all of the presentations now, but what you should do is you should jot down your questions in the Q&A section, and we'll have an opportunity at the end of the presentations to try and address questions and answers directly to the panelists. So thank you again, Richard. That was wonderful. So our second panelist is Marlene Haines, who's a doctoral student in nursing at the University of Ottawa. She's going to be speaking on Ottawa inner city health, harm reduction in the community. You should know that Marlene and I work very closely together, and she keeps me on the straight and narrow most of the time. So she'll be very informative for all of us as it relates to practical real world challenges in harm reduction. Marlene?
There we go. Hi, everyone. Hopefully you can see my slides okay. Thank you, Dr. Turnbull, for the introduction. Some people might notice that it is a change in topic from what I was originally going to be presenting on. I had submitted an abstract about harm reduction services in Ottawa, culture of drug use, a research project that I had undertaken previously. At the panelist meeting prior to today, it was decided that there might be some interest in speaking about some kind of frontline harm reduction work that's ongoing currently, just given the focus of this panel being frontline work. So as Dr. Turnbull said, I'm a nurse coordinator with Inner City, and I've been with Inner City since I graduated from nursing school, which is has been amazing. I'm also a PhD candidate. So my work and my research really reflect one another, which is wonderful. Currently, I'm focused on safer supply, which I'll get to, but just kind of as a general overview, Inner City focuses on working with individuals who are experiencing chronic homelessness to provide low barrier access to safe and high quality healthcare in the community where they are. There's a strong recognition of health concerns being complicated by aspects of trauma, substance use, mental health, and of course the lack of access to housing alongside other factors. So just as a very brief view, Inner City offers quite a range of services to the hard work and dedication of Dr. Turnbull and when I started the organization. We, access or provide many things across the spectrum of care, from primary care to end-of-life care. We have services within the shelter. Partnerships are always essential to the functioning of these services. Everything you see listed has partners involved as well. For example, Shepherds of Good Hope, Salvation Army, the Mission, John Howard Society are all very important partners in many of these programs. And this is just an overview of some of the programs Inner City wouldn't be able to do justice to in the 12 minutes that I have. So we'll just focus in on a couple of the crucial ones for today. So I'll start with our targeted engagement and diversion program. It's located in the Shepherds of Good Hope, quite an interesting and effective program. It operates 24/7, staffed with nurses, peers, as well as client care workers, social workers, etc. So essentially clients who are under the influence of substances, who are stable enough or deemed stable enough, can be diverted from the emergency department or cells to come to TED. Paramedics, police, OC Transpo services, other supervised consumption sites, people can self-refer. So there's a wide range of kind of how people can come and end up at TED. It offers clients a safe space where they can be monitored by nurses. It does alleviate the strain on the emergency department, which is great, but it also provides an option to clients who may not want to access the hospital and would feel safer being in care with nurses that they know and are familiar with in an environment that they are comfortable in. This program is often the start of engagement with clients as well. So if you see someone who comes through often, it might be a good place to start talking about medication, treatment, housing, accessing social supports, physical and mental health services, getting help to appointments, peers, all those sorts of things. We also have a managed alcohol program for clients who struggle with kind of managing their alcohol consumption, as well as maintaining housing on a regular basis. So individuals are offered controlled access to alcohol through hourly administration by staff. And this is essential. The pairing of, physical and mental health services, housing supports, life skills is essential to kind of the success of these programs. So there's a shelter-based program out of the Shepherds of Good Hope, as well as in enhanced supportive housing, which is known as the Oaks, where we also partner with Shepherds of Good Hope. So a common trajectory may be that a client presents to the targeted emergency diversion program repeatedly, often under the influence of alcohol, perhaps is voicing their concerns about their alcohol consumption. They may end up kind of going to MAP in the shelter and end up being housed at the Oaks, which is kind of just one example. Of course, everyone's different, but it just shows kind of the spectrum of services kind of across for clients to be able to see success in their goals and what they would like to do. Given kind of the forefront nature of the overdose crisis right now, and of course my focus through my PhD research will be on the overdose crisis as well, I decided kind of for the remaining time to really focus in on that and the services that, frontline services that are offered. So I'm going to be talking about things like OAT and IOT and our Safer Supply program, which is what I'm focused on right now. So just briefly, we do offer opioid agonist treatment. Suboxone is offered by our wonderful nurse practitioners out of the Mission Primary Care Clinic. They also come into the shelters or into our housing, services to offer clients care, accessible care where they are. Methadone, we are able to kind of partner with really important and crucial community partners, like, for example, the Sandy Hill Community Health Center, as well as recovery care, to make sure that clients can be kind of access services for methadone should they want that, as well as Cadian. We have a managed opioid program, which prior to doing Safer Supply was where I was working out of, and it was a lot of fun. We have a certain number of clients in the shelter who access our managed opioid program, as well as within housing. So for, generally speaking, it's for individuals with severe opioid use disorders who've tried. Clients are provided with a long-acting dose of opiates, such as it's usually hydromorphocontin or Cadian, as well as a long-acting form of opiate, which is liquid hydromorphone right now, which can either be injectable for the client within the managed opioid program. I did notice kind of an uptick in people leaning more towards the drinks simply because of having a lack of venous access. So it was a great alternative for people who struggled to really be able to find veins. Really exceptional outcomes for clients who are stabilized and housed. The housing unit that houses the managed opioid program is in partnership with John Howard Society, and just really, really incredible to see clients who previously weren't able to see that level of stability kind of in their lives. So quite amazing. And so what I'll focus on kind of now is the Safer Supply program for the remainder of this anyways, which is what I'm focusing on right now with Dr. Turnbull and our incredible team at Inner City, kind of getting this up and running. We've had it for over a year now, and it's really been expanding as of late. So for individuals, I think probably most people here know what Safer Supply is, but just in case people don't, it's a public health initiative that focuses on decreasing harms related to the toxic illicit drug supply. So focusing on things like the risk of overdose, individuals participating in criminal activity to purchase illicit substances, the associated traumas and mental health concerns with substance use through the prescription of pharmaceutical opiates. Includes the daily dispensing, similar to MOP and IOT of a long-acting opiate. We use generally Cadian for clients, although we do partner with, again, those outside organizations for clients who would prefer methadone, along with short-acting D for or D8 tablets. So sorry, Dilaudid 4 milligram tablets or Dilaudid 8 milligram tablets for cravings. Each client has their own goals, which are kind of always discussed, of course, at the intake and throughout the program, with the overarching goal being the kind of a reduction in the need to access the illicit drug supply and giving clients the ability to understand what they're using through safe pharmaceuticals. Individuals similar to MOP and IOT have generally tried OAT previously and are at this time declining it and have or have not found it to be effective for them in the past. So just to give you an idea of kind of what it all looks like right now and where we're at, I've included some photos. So the Safer Supply program with Intercity started out in a side office at the Shepherds of Good Hope building, which we were really grateful for and worked well for quite a while. And it's now integrated into a dedicated space in our supervised consumption site that's very fondly known as the trailer. And it's known as the trailer because it was literally ran out of a trailer for a couple of years and it worked really, really well and was wonderful, but it has since now just recently moved inside into a new space. Pardon the hearts, just trying to cover people's faces. So you can see kind of just a couple snapshots. This was before the space was open, just in the days previous to opening to clients, but it's still called the trailer, even though it's not in a trailer, just because, again, it was called that for so many years. Just kind of what the name of it is now. I was told that it sees 180 to 200 visits a day, which makes sense to me, but I was still surprised to hear it's, you know, quite a busy service, 24/7 running supervised consumption site. And the reason why the trailer is so important to Safer Supply is Safer Supply does have a dedicated backspace for Safer Supply. So I will, that's more of the trailer. It's so nice. Pardon the photos. I was taking these when I was really excited to be getting to peek into the space. But we have a back area, which is fairly unique for Safer Supply, where clients can meet with nurses, can meet with peers to check in. Clients can pick up medication between 8 a.m. and 10:30 p.m. 7 days a week. So it really offers a nice wide period for clients who maybe don't have as regular sleep schedules, and they can come in when suits them to get their Safer Supply medication. We also do regular check-ins with clients back here to assess substance use, you know, complications that are ongoing with their substance use, how their cravings and withdrawals are managed with their Safer Supply, how their tolerance is, and also we have, you can see on the right photo, and I'll show the little bit nicer. There's 3 for supplies just to assess their tolerance, to ensure that we're kind of dosing adequately, that we're safe, they're safe before they move to carries. The space is also evolving for, and I think it will continue to evolve, but it's evolving for other purposes. For example, clients who feel targeted in the community, who maybe don't feel safe carrying their Safer Supply with them, they will sometimes leave their Safer Supply Dilaudid tablets with the nursing staff, and they'll come in and kind of ask for whichever number of tablets they'd like and use, and then leave and come back later when they'd like more. And the clients have kind of requested that on their own, and of course, we're happy to do that to support them. Similar to kind of all our other programs, we're working really closely in partnership with other community agencies and organizations like Recovery Care, Ottawa Public Health, Sandy Hill, Somerset West, Respect Pharmacy, etc. And we're also working to create new pathways. Safer Supply, some of them can pick up their, or are starting to pick up their daily medication with us, kind of a one-stop place to get things. They're able to see a psychiatrist if they'd like, mental health nurse. They can see a housing and social support worker. And just as of late, Dr. Turnbull and I have been working to create new pathways to provide low barrier access to things like HIV PrEP or HIV treatment, as well as Hep C treatment, for a subset of the community who maybe wouldn't be able to access it before. So that is pretty much it. And I think I'm at time. And I look forward to when people have questions. Thank you.
Thank you, Marlene. That was excellent and gives you a broad spectrum of the different harm reduction strategies that can be engaged, and in particular, one that's more challenging recently and more innovative, and that's safer supply to deal with that toxic drug supply that we all face in our different communities. So our next speaker is Kourteney King, and she's an MA student, adult education and community development at the University of Toronto, and will be speaking on criminalized and pathologized, the ethical dimensions, ethical tensions of harm reduction case management when supporting people who use drugs in acute mental distress. Kourteney?
Hi, everyone. As I was introduced, my name is Kourteney King, and I am a master's student in the Adult Education and Community Development Program at the University of Toronto. Today, I'm just going to be presenting a portion of my master's thesis research that I've been working on for the past couple of years. This research is really grounded in my own personal experiences and challenges working as a street outreach worker, particularly in the city of Kitchener, Ontario. And the research really stems from moments of the work where I had to navigate ideologies and practices of our legal and health institutions on the one hand, while attempting to stay authentic to the ethics of harm reduction on the other. Can you guys see my slides okay?
Yep.
It's not showing up for me. Sorry, I just couldn't see my slides. Okay, there we go. Yep. Sorry.
We can see you.
Yep.
Okay, so just quickly for my agenda, I'm going to give a quick overview of the scholarship on harm reduction ethics, and then I'm going to review my research questions with you. I'm then going to lay out the conceptual framework of spiritual pain and end with a look at some of the findings around the ways in which the disjunctures between the street outreach workers' harm reduction ethics and their practice was contributing to spiritual pain. So just quickly, for this research, I specifically spoke to community-based street outreach workers that identified as working from a harm reduction model. And as we know, harm reduction is generally understood as both a philosophy and a set of strategies aimed at reducing the harms associated with drug use. It's rooted in social justice, and harm reduction moves beyond the limits of a traditional biomedical model with its recognition that drug use does not happen in a vacuum. And by embracing a harm reduction approach, the objective becomes using collective power to transform the social context of drug-related harm rather than helping individuals to cope with these forms of oppression. But over time, community-based harm reduction has become increasingly folded into the state, which is evident as evidence has accumulated regarding its effectiveness in saving lives. We've seen this in the AIDS movement. We've also seen this in our overdose prevention sites more recently. And understandably, this state influence has created a more institutionalized harm reduction that follows particular practice protocols that can often depart from a grassroots model of harm reduction. So in the literature, there's some really strong criticisms of this institutionalized public health adaptation. And in that it takes a very top-down, more individualistic approach that has a primary focus on risk management. And some folks have identified that this co-opting of the harm reduction movement is characterized as, can be characterized as dangerous for people who use drugs because it tends to erase much of the context that shapes the harm of illicit drug use, such as the criminalization of drugs and the people who use them. As a street outreach worker working from a harm reduction model, these are important criticisms to recognize, as the role of street outreach work walks a fine line between being transformative and also being just another form of governance and control. And for me now more than ever, I think as we face multiple public health crises, including the housing crisis, COVID-19, in the continual devastation of the overdose crisis, it's a really critical time for harm reduction in Canada. And I think that as a street outreach worker, we must resist these practices that compromise our harm reduction ethics by keeping people who use drugs at the center of the work and continuing to critically reflect on and challenge oppressive power relationships that shape our work, and most importantly, that shape the realities of people who use drugs. So here are my research questions. For today, in the sake of time, I'm going to just speak to the first question, which is, what ethical tensions do street outreach workers who work from a harm reduction model experience when supporting people in acute mental distress that use drugs? And I'll highlight a little bit of the second, which is, what impact does navigating these ethical tensions have on street outreach workers' experience with spiritual pain? The third, that I won't get to today, but that brought some really interesting answers from folks, was how might the answers to these questions guide us in creating a harm reduction response to people who use drugs experiencing acute mental distress? So for the research, I had the opportunity to speak with 7 street outreach workers who provide case management to street involved community members. Some of the caseload, or all of it, were folks who also use drugs. And as part of the recruitment, I targeted street outreach workers who worked specifically from community-based organizations in the downtown core of Toronto, and that self-identified as working from a harm reduction model. So just quickly, I'll go over my conceptual framework that I use for my research. I'm sure a number of you listening will be familiar with the work of Vicki Reynolds, but for those of you who don't, I'll take a second to introduce her concept of spiritual pain. So Vicki Reynolds defines spiritual pain as a discrepancy between what feels respectful, humane, generative, and then the contexts which call on us to violate the very beliefs and ethics that brought us to the work. So according to Reynolds, spiritual pain really needs to be viewed as a resource and as a point of ethical investigation for our work, because it offers an insight into how spiritual pain becomes present in our day-to-day work, but also offers a direction for resistance. So the application of spiritual pain is really underdeveloped in the literature. And for many reasons, it's a concept that I believe strengthened my investigation into the ethical tensions that these street outreach workers were experiencing. So to get a sense of some of the decision-making process and how street outreach workers came to be involved in the intervention of individuals who use drugs in acute mental distress, I thought I'd present a vignette, and it's really just a composite of the stories that were shared with me by the 7 outreach workers I had the opportunity to interview. So I'll go ahead and read it for you guys. I usually turn my phone on during my transit into work, and so on this day, I had like 10 missed calls from a client of mine, Nikki. She was speaking fast and erratic and begging for support to find her housing. Nikki has been restricted from all women's shelters in the downtown core, and often in relation to her methamphetamine use. Because of her history of sexual abuse, she refuses to sleep at a mixed-gendered respite center, so she has been without any shelter for the last couple of nights. She is super vulnerable out on the streets all night, so yeah, I was really worried about her. Anyways, so instead of heading to the office, I went straight to the park where I can usually find her, but she wasn't there. I just let some of the folks know in the community that I was looking for her, and I headed to an appointment with another client of mine. Later on in the day, I got a phone call from a community drop-in that's affiliated with my organization. They tell me Nikki is there and asking for me. They also tell me that she was found using on site, that she is high and disrupting the community space, and that she'll have to take some space for a couple of days. So I head over immediately, rearranging my appointments that I had scheduled in the meantime. When Nikki sees me, she's frustrated with me. Although I have tried, I do not have a housing option to offer her, and she becomes more agitated. It is clear to me that Nikki is also visibly paranoid and talking to herself. I tried to sit with her and calm things down, but at a certain point, it becomes clear that I am not going to be effective in de-escalating the situation. It was nearing the end of the workday, and the last time I worked beyond my hours, I took some heat from management. However, taking into consideration Nikki's lack of shelter and the cold weather, I'm obviously extremely concerned for her mental well-being and her overall safety. So this vignette, it really reflects a common, if not everyday experience that the outreach workers were vocalizing when I spoke with them. And really from here, workers took one of 2 directions as far as how they continue with their intervention. So from my conversations with the street outreach workers, when workers were unable to de-escalate the situation themselves, they engaged in one of these two responses that you see on the screen here. There were those that would continue to try and resolve the crisis within their community response and their resources available to them there. And there were those who made the decision to support or advocate for their client that they needed external institutional intervention. So for the sake of time, I'm just going to focus on street outreach workers who made the choice to advocate for a more institutional intervention to the crisis. And so for those individuals, when I asked them how an institutional response aligns with their harm reduction ethics, it became really clear it did not. And it was at this point where the practice shifts from harm reduction to more of a harm minimization. So workers began to speak about their motives in very different ways than they had in previous scenarios they had been speaking about. For example, a number of street outreach workers felt that even though they knew that having their client admitted to a mental health institution would not resolve the core issues, and that the outcome was likely not to be as beneficial as they hoped, they found comfort in knowing that the individual would have a safe space to sleep that night. Others identified that it was simply an attempt to break the cycle of someone's use so that they could get rest and reset and hopefully have some safety in the next day. For a small portion of the street outreach workers I spoke with, engaging in a more institutional response was connected to elements of professionalism, such as having an organizational protocol that they had to follow, in that if somebody was escalated, they had to call police and they had to engage in that institutional process. Where others, it was just simply passing the onus of liability from the individual, the worker themselves, onto the institution. So there were a number of ways that ethical tensions came into the work of street outreach workers when they were navigating this situation, once they had attempted to enter this institution of mental health. And as simple as deciding to support in an institutional response to a person who uses drugs, it is a conflict with the harm reduction ethics because of the two pathways that typically gatekeep access to the resources in that institution. So the two ways that people were identifying this access was involved calling 911, which almost always engaged in police activity, and others who had access to a clinician would enter the system that way, and that was typically through a psychiatrist or a family doctor. So these options are harmful in that they often involve police, and they often criminalize the individuals who use drugs, and also pathologize the distress that an individual who uses drugs is experiencing. So if and when a street outreach worker was actually able to obtain access for their client into a mental health institution, another clear conflict arose for them, in that our health and mental health institutions have been and continue to be harmful spaces for people who use drugs. The mental health institution causes harm in a number of ways because, right off the hop, engagement typically involves it often occurs involuntarily, and often without the consent of the individual who's in distress. And practices of mental health institutions have been characterized as quite coercive and predominantly take like an abstinence-driven stance. So yeah, there was a lot of tension arising in kind of both those points that people identified. But another element, so street outreach workers also highlighted that elements of the response, such as these, created a clear ethical tension, and it was evident that that was resulting in spiritual pain for them. When talking with the street outreach workers, workers' orientation towards harm reduction fell on a spectrum that ranged from grassroots to what the literature referred to as a more institutionalized harm reduction. And how street outreach workers fit on this spectrum, it seemed to directly shape their experiences of spiritual pain. So for workers who fit a more grassroots orientation of harm reduction, this tension was felt stronger, whereas those who leaned more towards an institutional orientation of harm reduction, more individualized, more institutionalized, they seemed to accept this response as just the way things had to be done. And so why this is important, well, it's important for a number of reasons, but the first is that those who do align with a more grassroots harm reduction model feel they must take up this interaction, are no longer able to work in alignment with the ethics that brought them into the work. And as a result, these workers were feeling less sustainable about the work, and two of the individuals I spoke with actually this was an element that led them to transitioning out of the role. So we're seeing our we're seeing our grassroots workers that are holding onto that ethic feel like they can't sustain the work long term, and we're seeing them exit the role completely. And so for, I guess on the other scale, I mean, to add to that, I guess, is like as a result of their deep spiritual pain, they are leaving the work. And so for those that were on a more institutional orientation to harm reduction, although they might not be experiencing spiritual pain to the same extent consciously, this type of crisis situation that they're engaging with, they're doing it without questioning it, which is a problem in itself because it's reinforcing the status quo of criminalizing and pathologizing people who use drugs. And we're consenting to this kind of treatment, this kind of coercive and involuntary treatment of people who use drugs. So that's kind of where I'm at in my analysis. And really, I just kind of want to highlight that it's an important time for street outreach workers to resist these practices that compromise our harm reduction ethics, and that we need to really do what we can to attempt to keep people who use drugs at the center of our work and continue to critically reflect and challenge oppressive power relations that we often see in mental health institutions. And then I think it's really important that we include that in our resistance and transformation, that we include our current response to folks who use drugs experiencing mental health distress as a point of reflection and a point of resistance. So the next steps I'm taking is completing analysis on the third research question of my thesis, which was how might the answers to these questions guide us in creating a harm reduction response to people who use drugs while they're experiencing acute mental distress. I'm planning on working with some of the street outreach workers from my research to co-author and publish on the responses to this question. Had a lot of great feedback from the participants in the research on that. And I'm also hoping to share findings with community organizations that have street outreach workers in Toronto. And yeah, those are my next steps. Thank you, guys.
Thank you very much, Kourtney. That was wonderful. Our next speaker is Thomas Foth. He's a professor of nursing at the University of Ottawa, and he'll be speaking about moral economy. Thomas?
Hello. Can you see me? Can you hear me? Okay.
Yes, we can.
Okay, the title of my presentation or my paper is The Moral Economy of the Movement for Overdose Prevention Sites, Civil Society and the Management of the Opioid Crisis. And I will read my paper because I want to stay in the time frame. So the reasons I'm interested in the campaign around harm reduction is that they demonstrate how our political engagement had changed. Moral sentiments have become a central stake in current politics, particularly in the ongoing pandemic. They underlie legitimate political actions, particularly if they are directed at the helpless and the powerless, like person who use drugs, the homeless, or the poor. Moral sentiments are combinations of effects and values like empathy and altruism that draw us to the misfortunes of others and make us wish to alleviate their suffering. Some philosophical traditions understand the experience of sufferings as that which enables us to know what is good. For example, sympathy for the unfortunate is symbolized in the Christian parable of the Good Samaritan, the only one who cares for a man left dying in the street by thieves. It is the paradigm for current politics of compassion and for Western moralism, even though it goes far beyond the Christian doctrine. Our societies are characterized by moral sentiments in political life, or what we could call a humanitarian government. Although the governing of humanity is not a new concern, today new forms of governmentality have emerged, particularly in the international context, that are characterized by the importance granted to NGOs, corporations, and international actors in the governing of localities and space. The harm reduction movements can be considered a form of governmentality that governs urban spaces of homeless, person who use drugs, prostitutes, etc. NGOs in this context are protectioners of humanity, speaking on behalf of those who are excluded from humanity. Humanitarianism as such has become a new mode of governing in the name of humanity. Thus, humanitarianism does not replace, but rather complements governments and must be understood as languages of values and effects that justify specific practices in the governments of humans. But governing in the name of a universal humanity contributes to the growth of governing technologies that intervene on another dimension and with different targets, such as harm reduction. Harm reduction is not about replacing governmental structures to address the root causes of addiction and homelessness, but is a different way of governing persons who use drugs by claiming humane treatment. Harm reduction thus has become a supplement to public health policies in the name of humanity. This form of governance has also transformed the object of governance, like the young drug user who was perceived initially as a potentially dangerous delinquent, but was transformed into a suffering being who must be protected against himself, herself, her deadly drive, and above all, the risk of deadly infections. What changed is not the person who used drugs, but our attitude toward him or her, as in the case of the police, who yesterday were mandated to arrest them and today are asked to ignore them when they approach a needle exchange facility. In the past, voluntarism contained elements of political resistance, but today, volunteers participate in organizations that provide medical or other forms of humanitarian support. Thus, humanitarian reason transformed deviance into suffering and political resistance into humanitarian assistance. This new moral economy with humanitarian reason at its centers pay particular attention to the suffering and misfortunes of others. Before I continue, I want to emphasize that I have the highest regard for the work of the activists and the volunteers and frontline workers who literally save lives and who were and are, as in the case of the overwhelmed overdose prevention site in Ottawa, the targets of violent outbursts by bystanders and police forces. Furthermore, humanitarianism is increasingly used at a time when right-wing populist politicians are trying to roll back even modest achievements in the treatment of persons who use drugs. It seems, however, that the only subject position available to those who are against the increased coercion of people who use drugs is humanitarianism. However, I want to ask how this ethics of politics has imposed itself today, how we have come to the point that we prefer to talk about sufferance instead of justice, and what is political at stake in this transformation. And I also want to suggest that humanitarianism is not only beneficial, but can harm those it is supposed to help. That is, I argue that the narrow conceptualization of emotions evoked by the idea of humanitarianism, such as compassion, empathy, pity, and benevolence, restrict possible responses. The logic of humanitarian reason is the moral history of our present time. It consists of actions like listening to suffering voices or assuming the beneficence of compassion that we consider a priori as good. To question these moral evidences means breaking a general consensus and risking being accused of relativism and cynicism. This is particularly the case in regard to the overdose prevention campaign or harm reduction movement. In these contexts, it becomes difficult to exercise critical thinking because humanitarian reason appears morally untouchable. However, it is politically important to understand the politics of suffering and how humanitarian morals have been inscribed in politics. My question is, can we find another form of political care that goes beyond care as welfare provided by governments and beyond the benevolence of humanitarianism and compassionate care? Humanitarianism as an ethics of politics is based on a paradox, because on the one hand, moral sentiments are directed toward individuals who are poorer, more miserable, and more vulnerable. In other words, it is a politics of inequality. On the other hand, the precondition of these emotions is the recognition of the other as equal. The politics of compassion is a politics of solidarity. This tension between inequality and solidarity, between domination and the relation of mutual assistance, is characteristic of all humanitarian governments. It is because of this underlying paradox that the benevolence of donors and agents often turns into indifference or even aggression against the sufferers, what is called compassion fatigue. And those who receive the gift without being able to offer a counter gift often feel resentment toward the ones who do good. Harm reduction is a relation of power between the donor, who literally gives back lives as a gift, and the receiver of this gift, who becomes the recipient of compassionate policy from above. This asymmetrical power relation is not a psychological or individual problem, but rather a sociological and political one, because the conditions of the social relations are beyond individual intention, making compassion into a moral feeling without the possibility of reciprocity. Even if the gift is given without interest, it supposes a counter gift in the form of an obligation, like the obligation to show recognition of the good deed, binding the recipient to the benefactor. On those who are the objects of humanitarian attention know well that what is expected is humility and not the claiming of a right. Humanitarian reason always governs precarious lives. The unemployed in search for work, the person who used drug as risk of HIV infection or overdose, the victims of catastrophes or wars. Compassion in public space is always directed from the top to the bottom, the more powerful to the powerless and victims of their fate. Precarious lives are existences that are not assured but are granted. In other words, they are not defined in the absolute, but rather through the relationship they have to those who have power. Humanitarian government is a government of precarious lives, and compassion is limited by the hierarchies of lives within humanitarianism. There is no way to circumvent this distinction. This paradox of humanitarianism is due to the interplay between the ideal of universality and the practice of difference that is produced by the material inequality between the humanitarian and the victim. Real human solidarity would only be possible if material equality existed. And again, this is also true for the harm reduction movement, which is not about equality, but characterized by this implicit tension between the ideal of universality, every life counts as equal, and the practice of difference, the activist and volunteer who lives in a secure material condition. The history of harm reduction is an example of how moral sentiments have been inscribed in the 20th century with the emergence of humanitarian organizations and the right to intervene in the name of humanitarian reason. Thus, it is not about changing unequal living conditions and trying to improve life on a broad scale, but rather alleviating suffering and pain right now in the present moment. Long-term improvement of life conditions are not part of humanitarian intervention, despite the fact that it might be mentioned sometimes in the background. The focus of attention is on immediate response to an emergency, as in the case of the so-called opioid crisis. With the advent of humanitarianism and the idea of social emergency, medicalization of the social took place. In humanitarian emergency interventions, emphasis on the suffering body becomes the guiding principle of all action following socio-political logic of caring. Emergency humanitarianism represents a specific politics that defines life as physical survival and is based on a universalism that perceives parts of populations only as suffering individuals. This emergency humanitarianism has developed large apparatuses of humanitarian government consuming great amounts of resources, thus limiting those resources available to develop long-term political responses or visionary political projects. Again, what characterizes new humanitarianism is that it responds to situations of suffering that are the result of increasing inequality and injustices without addressing the root causes of the suffering. Harm reduction and the overdose prevention movement must be understood as part of this charity or new humanitarianism, meaning the sufferer is rescued through biomedical intervention, thereby prolonging and extending his/her suffering and depoliticizing the situation in which drugs are used. That is, the historical and political forces that make life precarious and certain lives more precarious than others. At the moment when neoliberalism increases precarious living conditions and intensifies repression, like the dramatic increase of incarceration, what some call the politics of prison fare, humanitarian, medicalized, patronizing services exploded, often provided by NGOs and volunteers trying to soften the dire consequences of these political transformations, as in the case for the overdose prevention movement as a question of health and a public health emergency. Not addressing the root causes means perpetuating the inequality and restricting visions of possible alternatives. Okay, thank you very much.
Thank you very much, Thomas. I just remind everyone as we head into our last presentation that they can send questions through their chat line. So our last presentation is from Gord Garner, who's the Executive Director of Community Addiction and Peer Support Association. He's well known to many of us. He'll be speaking on Pillars Before Purpose: Has Stigma Affected the Language of the Four Pillars? Gord?
Hey, everybody. So I guess I can't see you, so I'm assuming someone's going to say something if you can't hear me. Am I coming through okay?
You're good.
Good. Okay. So every once in a while I get to these things and I feel like everybody's talking about me, and now anyways, here I am. So thank you everybody for the information they shared today. And it's a little image that we came up with Rebecca Jessman from the Canadian Center on Substance Use and Addiction. Stigma sitting on top of these pillars that block them from lifting anything up and separate them. And down here is what we're actually trying to achieve moving through this. And so I want you to know that I fully support all methods of increasing people's wellness. And so the harm reduction movement does that. So I guess you can say I fully support the harm reduction movement, except for I just want to change the language around that so that other people can understand. And so, but I go and talk to all the pillars. I'll be seeing the Ottawa Police on Tuesday and talking about their members who use substances and the need for compassion and practice and language change in there. And so, you know, one of the things I like to see changed, of course, is treatment. I mean, what does that mean if 66% of people that go to treatment have recurrences when they come out? Can you really, is treatment the right term, or is it just education, harm reduction, and stabilization period on something that can be very difficult? And if harm reduction increases well-being, why don't we say that? And then why would we say that? And prevention doesn't mean we can't stop substance use. What does it mean anyways? And the purpose of enforcement and policies increase well-being, not punishing and suffering people. What would we change? And so you can see if we have this lens that matters. So how does it affect language around harm reduction? The specific terms used to describe harm reduction services may make a big difference in the public's acceptance and support of them. It's a strong ideology, stigma related to substance use and harm reduction services has hindered the implementation of these evidence-based interventions. Specifically, stigma may hinder service implementation by decreasing public support for harm reduction strategies and increasing public support for punitive policies. I think that's what everybody just kind of said in broad terms in many ways. So they surveyed 2,000 people presented with 3 facts about opioids and opioid-related overdose deaths. Half were given a definition of safe consumption site, whereas the other half were given the definition of overdose prevention site. And guess what happened? 45% of people without any further information support the legalization of overdose prevention sites, whereas only 30% support the legalization of safe consumption sites. So 45 isn't 100%, don't get me wrong, but it's a much bigger number than 29%, as you can see by the visuals there. So the idea then that there's a societal opinion already about the sanctity of life that can be accessed by the change in language, there is all kinds of society support for increased wellness. Person first language training, stigma reduction is a critical component to address the level of stigma. Framing language in the context of substance use disorders that can reduce stigma and overcome ideological barriers has the potential to increase support for public health oriented policies and decrease the support for punitive policies. If we put wellness on top of those pillars and we drive health, human rights, and evidence through those pillars, you're going to get policy changes. You're going to get all the decriminalization, as Richard mentioned, will take place. Harm reduction and treatment will merge into some sort of activities to increase wellness around people who use substances. And prevention will become not prevention, but information to increase wellness and relationships to substances. I've gone a little fast today. I'm gonna come back and talk to you in person for a second. Yes, you know, there's a lot of great information today, and I have a few minutes to share that. So I guess at the heart of all my messages, when I go and talk to people in treatment centers, and when I go to talk to law and policy makers, I'm always asking the same question. If you want to help someone quickly, would you try to change the mind of a bunch of Canadians who don't study this to understand what you're saying? Or would you speak in a language that other Canadians understand and would support? So is the purpose to have a treatment pillar? Is the purpose to have a harm reduction pillar? Is the purpose to have a prevention pillar? Is the purpose to increase the wellness of Canadians in regards to substance use? And if that's our purpose, then what language will we choose to use? And I'm going to wrap it up there. And those are questions. I don't have the answers, but there's some indication that our language will, in fact, affect how quickly we can help people, those who are suffering. And I may kind of look like a grandpa figure right now, but I had quite a life, and a good friend of mine experienced 4 overdose reversals in the last 2 weeks. And so I do have a big shout out to Ottawa Inner City Health and all the work that people are doing. I only wish we could move a little faster in the societal support of this meaningful work. And I think we can do that through language. I'm not sure what you think. Thanks.
Thanks very much, Gord. That was wonderful. And lots of challenges. So while everybody's thinking of questions, I think I can see one question in the 10 minutes or so that we have. And if we need a little bit more time, I'm told by Vanessa that we may be able to steal a minute or two if we need it. But let's begin with some of the questions that we have before us. Some of them relate to actual the pragmatic aspect. This relates perhaps to Richard most. Some of the pragmatic aspect of moving people towards supporting safe injection facilities, government supporting it. Gord highlighted some of the challenges there. So how do we get some of our decision makers to be more supportive of moving in the direction of SCSs throughout the country? Richard, do you think you could start with that?
Sure, happy to. And I typed a few thoughts in response in the Q&A box, which is public, I think, but happy to just add to them. Thanks for those questions. And, you know, I wish I knew, I wish I knew what the answer was, or that there was a magic bullet to do this, but I don't think that there's any real magic. I think it's a long, ongoing process of challenging people's prejudices and the stigma that surrounds drugs and that is directed toward people who use drugs through two things, well, maybe three things. One, it's through evidence, of which there is a lot, about the harms of criminalization and the benefits of decriminalization and of putting resources instead into the health services that are needed to reduce harm and promote health. The third thing is to show that there is, or the second thing rather, is to show, is to reach people through at an emotional level. And so I think we need those compelling personal stories, horrible as they are and difficult as they are for people to share and to reshare and reshare in an attempt to get people to pay attention and listen. But they are powerful. I think we have ample evidence that often evidence alone and logic isn't enough to change policy. And to get policymakers to do the right thing, you need to change people's hearts as well as their minds. And personal stories are really, really, really important for doing that, including the stories of loss and of other kinds of harm that could have been prevented if we had more sensible policy. And then I think the third thing is to show that it's politically safe for policymakers to do the right thing. They rarely will be the ones to lead. There are exceptions which should be celebrated, but more often than not, they will follow once the space has been made politically for them to do the right thing. And that, I think, means that we have to emphasize over and over and over again the widespread and growing support for decriminalization and for harm reduction services like SCS and other interventions. So that eventually they can be pushed into taking that step into that space and changing law, changing policy. And so the more we can show a growing consensus about the need for change, the better, I think. It doesn't mean it's going to happen, but the better.
Thank you very much, Richard. I can say that right at this particular minute, the Senate is now formulating policy as it relates to decriminalization to put forward to the Parliament for consideration. It may not pass, but at least that conversation is starting to take place in the Senate. So that's interesting.
Yeah, and if I could just add to that, there are two bills also before the House of Commons that would fully decriminalize simple possession or would go partway toward decriminalizing simple possession. They are not government-supported bills. They are private members' bills, but they also are provoking and will provoke in the weeks ahead that conversation. So that's great.
And the police chiefs have just come out supporting decriminalization, not legalization, but decriminalization. So also positive. I think the trend is moving in that direction. So thank you. And thank you, Gord, for trying to get us to talk about the right things. I was struck too by, in several of the talks, and I'll put this to some of the panelists, that there seems to be this disconnect that causes great ethical challenges that Kourteney talked about and others. And that disconnect between our institutions around us that perhaps do not support as thoroughly a harm reduction strategy, and those on the front line who are faced with the pragmatic reality of life on the street. And that disconnect, I'd love, Marlene, for you to talk about your experience when people go to hospitals or jail, or to hear about how those broader organizations, their perception of harm reduction just is a great conflict with those people that are on the front lines. So Marlene, do you want to begin? And then I think we expand it to perhaps Kourteney.
Sure. Absolutely. I feel fairly lucky because working with Ottawa Inner City Health, a very established organization in the community, I would imagine it's a very different, it's just a very different experience than maybe other people who are working on the front lines in harm reduction and who don't have kind of that established kind of presence. And with that also, I talked a lot about partnerships. That's a really big thing for making sure, you know, across the continuity of care, there's kind of cohesiveness for the clients in the way that makes sense for them. I think that the reason I wanted to do my PhD and continue to work clinically was exactly to kind of bridge the two worlds of kind of the research policy side of things with the frontline clinical work, because there often is a disconnect, and there often is misunderstandings between the two, and I think that they can function very well together and should function very well together. But it's going to take people who kind of have an understanding of it all to move forward in ways that are meaningful. And I also think that it's different when you're working directly with the clients where they live, kind of in a shelter maybe, or in encampments or whatever that may be, and seeing them day to day, developing those relationships, developing the understanding, the trust, the respect. That's different than somebody maybe showing up into the emergency department. Maybe you've never met them before, you don't know who they are. That's an incredibly different experience and relationship between kind of provider and client. I would imagine it's similar elsewhere as well. Yeah, so it's going to take a lot of work, and we're going to need, you know, clients and peers and the help of everyone to kind of build that.
Kourtney, did you have any further comments about this disconnect? And you certainly referred to it and how that caused sort of moral challenges and distress.
Yeah. I mean, I'll echo a lot of what Marlene just kind of said, but I think from a street outreach worker perspective, one of the two key parts of the role are system navigation into external organizations that include social and health institutions. And the other hand is crisis management. And what was happening and what happened in my own time as a street outreach worker is we, as a community, can work in a way that aligns with our harm reduction ethics when we are supported from organizational policies and practices as well. But there's a certain point when it comes to a crisis, when things escalate, that, you know, the amazing nurses, community nurses and stuff can only do so much. And then you have to kind of see this kind of moving into the institution. And that's really where that kind of disjuncture and that conflict happens for folks. Is that there is a lot of ways we can do it in community, and we're doing great work in the community to center people who use drugs. But at a certain point of the crisis, we still are dependent on health institutions for the resources that they have access to that we simply don't. And so, yeah, I think that, yeah, that's a real tension in the work that we still haven't sorted out. And I think even when you have, whether like there were some folks who had kind of organizational constraints that limited them to work within their harm reduction ethics, and there were some folks who don't. But no matter what, even the folks that that didn't call police, that didn't engage in the institution at all for a mental health crisis, still brought up that they were not willing to do that because of the harm they've seen, which then places it back on the worker, right? We're seeing, and most importantly, the person who's suffering. So the person who's using drugs, who's in the community and experiencing that distress and that crisis, isn't getting the services that they should be.
So I just, if there's any last questions from the audience, I'll ask you to just put it into the chat box. And my last question actually relates to what I thought it was fascinating to hear Thomas speak and then Gord speak. Thomas was cautioning us about a compassion-based humanitarian type of approach, or at least flagging that. But Gord, in his presentation, put it in a human rights context. And, you know, I would wonder, Thomas, is that the approach to be starting to think about? Is this these elements of harm reduction in the opioid crisis or in other settings, is that a fundamental human right that we should be trying to advocate change on using a rights-based perspective?
Thank you. Gee, the technology. Yeah, I'm not sure if I would advocate for a human rights perspective, but I found interesting what Kourteney said about this ethical dilemma that if there are certain situations, then we still rely on the institution that contributes. So basically, we call the police in order to find a solution for certain situations. And I think that's perhaps demonstrate the dilemma in which the harm reduction approach finds itself, because I think, honestly, we need to change the society in which we live. So the problem that I see is whatever we try to do with harm reduction, even if the Senate might change the legislation, that doesn't change that we live in a society where people basically kill themselves because they are just despaired. There's no future. There's like what we produce today during the pandemic are the people who will use drugs tomorrow. And I think what we need to do is to realize that it's perhaps a little bit what we see now with abolishing the police or reforming the police, that we need to abolish a system that produces precarious lives that then are kind of treated by volunteers with a humanitarian approach. I don't know if you can follow me, but that's, I think, the dilemma. And the other thing is that the way how we address injustices, so whereas in the 1968, so when we were young, where there were kind of political movements that asked for justice, and today what we ask for is that people do not suffer. It's like the political perspective changed, and I think that's very dangerous in the society we live in.
Thank you. And Gord, any comments? I see you wanted to talk about the decriminalization piece too.
Well, you know, I'm a verbose person. Am I on there? Can you hear me?
Yes, we can.
So, and I realize we're winding down, so I'll try to rein myself in. Number one, 60,000 Canadians died last year from substance use. Our silence about the other 55,000 really speaks to stigma, speaks to an acceptance of a population that is mostly hidden. Although the level of street engaged people that are involved with substance use is high, that population of people who use substances that are on the street is really low compared to the broad population. As long as we're making it about the people outside the window of the car, it'll be about the others for most of Canada, you know? And so there's this inability to get political strength behind these movements because we keep thinking we're talking about other people. If we had the 500,000 Canadians that every year grieve the loss of a loved one to substance use disorders or substance use, publicly speak out about this issue, it wouldn't take very long for the politics to follow that, you know? And then someone who's been homeless, someone who's experienced a lot of harm reduction services, someone who's been to the hospital, been in the back of the police cruiser, you know, those are very strong memories that I have, you know. But someone who also had a lot of behavioral issues, that harmed a lot of other society members. There was times in my life I was not safe to be with. And so I want to respect that. We don't want to be too magical of unicorns out there that people are trying to help. There's times when we need to have an intervention that keeps our community safe. But in that, I think what you see here is a desire for the community to be safe, but that's all community members. I will put forward to you that people, and I'm speaking about myself here, that are street engaged often run into more services. They might not be the right services, they might not get the right help, but they're in contact with potential services on a regular basis. Person in a uniform in the police situation is educated, employed, he's got a union, he's got insurance, and is as far away from getting help from a substance use disorder as anybody I know in this country. Because they can't tell anybody there's something wrong with them. And so they will go to the far end of that spectrum in isolation and devastation. And so when we're looking at this, I really do believe that the ultimate harm reduction is the idea that we can examine our relationship with substances publicly without shame or discrimination and get whatever support we need. And that we have a country that is built on discrimination and is built on marginalization of populations for the benefit of others. That's the economic system we live in. My job is to get more share of the pie than is mine. Someone's not going to have any pie. And so the problem with Canada isn't the 250,000 people that'll be homeless month. It's the problem in Canada is the 33 million people that allow it.